So I'm very actually excited to tell you some things about new developments. So what we are going through, there is a lot of slides. We'll go through what actually medical thoracoscopy is, because I expected that some people who will be around won't have a clear idea what we are talking about, how we do it, why we do it, what we're afraid of. We'll talk about complications a little bit of results, and what is new actually in the field of equipment at the moment. So what is medical thoracoscopy? I know that you who are sitting here already know that's the endoscopic procedure in the lung cavity where we take samples and perhaps make a pleural disease. But I asked ChatGPT what artificial intelligence thinks about that, because the medical thoracoscopy is around for more time than we are around, and it developed when there were no mobile phones, no computers, whatever, more than 100 years ago. And the idea was to make a decent pneumothorax in the patients with tuberculosis. That's how thoracoscopy began. But now it evolves in many other indications. So now we distinguish medical and surgical thoracoscopy. Surgical thoracoscopy is usually used for lobectomies or bigger procedures, but medical thoracoscopy should be very simple. We use it for diagnosis of pleural diseases where we are not able to get a diagnosis for cytology. So we use thoracoscopy as quick, a simple procedure, mostly for biopsy and pleural disease. We don't remove lobes out of the chest cavity. We use local anesthesia and a bit of sedation. So even the patient with low performance status can tolerate it very well. And people who are submitted to this procedure, they breathe spontaneously. They don't need intubation and ventilation and general anesthesia and whatever. We do it in a partial pneumothorax, not with a complete collapse of the lung, and we use only one point of entry. We don't use 2, 3 or more like surgeons do. So surgical one is more complex, requires general anesthesia, intubation, anesthesis, and usually more points of entry. It's usually more invasive procedure. So our is simple, and that's why it's used quite a lot, and it improves our workflow with the patients who need diagnosis, and we are unable to do that. So why we do it? We have patients with pleural effusion. This is the main indication. We take thoracentesis, but we don't get the firm diagnosis. There are no malignant cells. There are some lymphocytes, but we don't know what kind of malignancy there is. If it is, we diagnose infections, for example, tuberculosis. In tuberculosis prevalent countries, it fastens the diagnosis very much. And if there is some kind of inflammation, for example, chronic rheumatoid arthritis, but in the cases where diagnosis cannot be established different way. We have several therapeutic options like pleural disease, which is most often used for patients who have malignant pleural effusion. We do some adhesiolysis sometimes in patients with infection and empyema, and that's mostly what we do. And there are some rare indications which I won't mention here. So pleural effusion has a very lot of causes, but mostly we diagnose mesothelioma, cancer, tuberculosis, and some idiopathic effusions which cannot diagnose other way. So this is our main group of indications. So why in the malignant pleural effusion, different carcinomas, lung cancer, breast cancer, whatever, differently shed cells in the pleural cavity. So some are very simple to diagnosis, and normal thoracentesis has a high diagnostic yield. But for example, in mesothelioma or squamous cell lung cancer, diagnostic yield of repeated thoracentesis is pretty low. It's 20-30%, and since we don't have diagnosis, we have to get in the chest cavity and take a piece of tissue to be sure what we have. What's the point in tuberculosis? In tuberculosis, when we use just pleural fluid, and that's not a clear empyema, which is very rare, I suppose. I practically see it once or twice in a lifetime, but there is a lot of non-empyemas tuberculosis effusion. We rarely find bacilli in the pleural fluid, and if we wait for a culture, we can wait several weeks before we have a diagnosis. But if we go and take a histology, and we can see bacilli under the microscope, we have the diagnosis in the same day. And we also have a bacilli for culture and to antibiotic tests. For example, if tuberculosis is resistant, we can do this pretty much faster, several weeks faster as classically. Indeed, that nucleic acid amplification has a high sensitivity, but we don't isolate bacilli, and we cannot make an antibiogram. And the Next thing is TARC pleurodesis. In Cochrane database, the TARC podrage is still the most effective way to make a pleurodesis in patients with malignant pleural effusion, and the semi-flexible thoracoscopy just made for it. How we do it? We do it simple. We don't need a surgical room for that. We can do this in normal endoscopy rooms, almost bedside. So the only requirement is to prepare patient as for operation. We use a lot of washing, a lot of disinfection. We cover the patient, and we do this procedure very briefly. Usually from entering of the endoscope to the end of the procedure, it's like 15-20 minutes. But preparation is much longer. Usually take half an hour before we start because of all this disinfection. The procedure goes like that. First, we check the patients with the ultrasound and select the right point of entry, where there are no adhesions, where there is only pleural effusion, that we don't injure the lungs when we enter with the endoscope. The next step is some local anesthesia and sedation for the patient, that it's calm, and then we introduce the pneumothorax. Pneumothorax is essential because lungs should be removed from the chest wall, that the endoscope is safely enters into the pleural cavity. So we do this quite often under the control of fluoroscope, but if there's a big effusion, you don't need a fluoroscope. You can check with ultrasound and make a artificial pneumothorax with ultrasound. Then we completely disinfect the patients, we cover it, and also put the foliage over the skin that we minimize the risk of infection. So there's a lot of this preparation, never enough of disinfection. And now then we have a very nice semi-flexible, semi-rigid instrument. It looks like a bronchoscope. It has a rigid shaft, but the tip is flexible. So we can look at every possible direction in the chest cavity, and the field of vision is much bigger than this rigid scope, because rigid scope cannot look upwards and in the direction where the thoracoscope is introduced, but only in several directions. But the semi-rigid, we can look everywhere. So the next step, very important, is access to pleural cavity. We have the flexible blunt trocars, which can adapt a little bit when we move the thoracoscope. It's not so rigid and doesn't make so much strain to the chest wall and doesn't introduce so much pain to the patients. The next step is maneuverability and inspection. Here I have a short movie, so I hope, yeah, it works. So you can see we can go everywhere. We can only turn thoracoscope back and we see our point of entry. And we can inspect all the chest cavity around, and there are no secret places for us. We see everything. So this with rigid thoracoscope is not possible. And then there is, what is important is biopsy. We have two modes, major modes of biopsy. One is forceps biopsy, the other is cryobiopsy. I go just further, and we are able to get a big samples of tissues. This is a surgical size of tissue sample, more than enough for pathological diagnosis, and also for all molecular markers which you need, and also for tissue bank. If you want to store some tissue for later and for some research, there's plenty of it. So it's more than enough. So the fear that with semi-flexible thoracoscope is not possible to take a proper sample is not on the place. Because for several years, for many years since the instrument was introduced to the market, it was told that it's flexible, you cannot get proper distant samples, but it's not true. The samples can be taken and they are big. And there was many times talking about what about mesothelioma. Mesothelioma is difficult to biopsy. As you see here, we can get a large chunks of tissues, even in the mesothelioma. Of course, we don't pull the forceps through the working channel like in bronchoscope, but remove it on block with thoracoscope altogether. And as you will see, I'm sorry that movie doesn't go fast enough, but pieces like of 2-3 centimeters. And since this is a malignant tissue, this doesn't hurt the patient, doesn't feel the pain, because we biopsy the cancer, not the healthy tissue. So when you see this on the glass slide, it's a really big one. So you need one such biopsy and you have more than enough tissue for all the procedures which you need. So the next step is a cryobiopsy. If we're not satisfied with the forceps, we can use cryoprobe. So cryoprobe is useful when we have nodular changes on the pleura. When you just have flat and hard pleura, it's maybe cryobiopsy a little bit more problematic. But in the cases when they have a nodular lesion, you just attach a cryoprobe to the nodular lesion, freeze it, and gently harvest it, and you get the whole piece of it. So it's, and you remove it altogether with a thoracoscope in order that you preserve the whole sample. So that's the trick. So results, I won't go through all the numbers, but diagnostic yield for rigid and semi-flexible actually just the same, and the cryoprobe as well. The cryoprobe has advantage when we have nodular lesions, not just flat pleura. This is flat pleura where the forceps are a little bit better for taking biopsies. This is nodular lesion where cryobiopsy has advantage because we are able to get significantly bigger sample with this method. So the next step, I'll just show you a little bit, is a pleurodesis. We don't insert the talc directly through the working channel of the thoracoscope because it may be dirty and blocked, but through the catheter, we introduce a catheter through the working channel of the thoracoscope, and we gently blow the talc into the space, not to the lungs, not to the chest cavity, but to the space that we have like a snowstorm. And this talc evenly settles on all surfaces of the pleura, visceral and parietal in a very thin layer and makes the best possible effect. If you just blow the talc to the lungs or to the chest cavity, we have accumulations of talc. It is not so nice and good if you have a thin layer of snowstorm at the whole chest cavity. So these are rare indications. For example, this patient had fluid of pneumothorax due to carcinoma. Here you see the fistula. And these lungs were not re-expandable because there is a fistula. And what we did was we identified the fistula during thoracoscopy and made a small electrocautery touch to close the fistula. And then it was possible to re-expand the lung and to put the talc into the same session. And the patient had effective pleurodesis and also spontaneous pneumothorax due to malignancy didn't recur thereafter. These are rare indications. You don't see them every day, but it's possible just with a small touch of electrocautery that you close the fistula, and then you can treat the patients and make him a lot of comfort and remove a lot of symptoms and hospital stays which those patients have. So you don't need a lot, just a little bit of touching and cauterization, and the fistula can be closed if you find such a case. So we'll go further. What we're afraid of. So what are the complications, possible complications? Complications, when you read the literature and even in the live practice, I have hundreds of thoracoscopies behind me, the complications are very rare. If you know your anatomy of the chest cavity, you know where the vessels are, where the heart is, where the lung is, and you don't touch the areas which you don't, for example, aorta or heart or such things, you don't have complications. You can take a biopsy safely. You just peel the layer of the pleura. You don't go deep into the thoracic wall, because what you're interested in is on the surface, not on the deep of the thoracic wall or in the lungs. So the best thing is that the worst complications are associated with poor patient selection. Patients who had cardiac dysfunction usually, or they have respiratory failure, or they are hypercarbia and so on, or they are very bad performance status like WHO 3 or 4. Sometimes when we perform a pleurodesis in a very old patient, inflammation which talc induces can also make a complication in such a patient. And if there is a massive pleural effusion, if we expand the whole lung into one moment, it can complicate. So we expand lungs slowly after the procedure. So when you are doing thoracoscopy, better don't. You go to find the publication, or this book I very much recommend from the colleague Philippe Astoul. When you have such things, be very cautious about that. If you have one patient with healthy lung and the other with massive pleural effusion, even if the patient has slow function capacity, you can do thoracoscopy on the site when there is a massive effusion, because there won't be any problems, but don't do it at the opposite side. So results. Let's go first for tuberculosis. Effusion, a low diagnostic yield, a closed needle biopsy. It makes sense in countries with high prevalence of tuberculosis as the first procedure. But in the low prevalence countries, this number is even lower, and maybe thoracoscopy is the next procedure in this area. Why is this important? Because diagnosis is getting in much shorter time. In the same day, we can see bacilli in the histological sample, and we can make antibiogram for possible resistance. If we wait for culture for pleural effusion, it takes weeks to that. and it's not so reliable. These are 30 years old data on malignant pleural effusion, cytology, biopsy needle combined, and thoracoscopy line. And these are the new data from 1 year or 2 years ahead, meta-analysis. Still the same data as 30 years ago. So thoracoscopy is very useful in that 1/3 of the patients where we cannot get diagnosis with fluid cytology. And even mesothelioma is much worse. Mesothelioma is more difficult to diagnose if it's not advanced, if it's in the early stages. So the same 30 years old data and just recent data are practically the same as they were 30 years ago. So histology makes a difference here. So why is this important? I already mentioned that certain cancers, they shed malignant cells very early, and a lot of it, like ovarian cancer or adenocarcinoma of the lung, but certain like mesothelioma or squamous cell lung cancer, whatever, cytological yield from pleural effusion is very low. So these are candidates for thoracoscopy when we have negative pleural effusion. This is again meta-analysis data. I won't go through all these studies, but you can see cytology around 60%, thoracoscopy diagnostic yield around 90% when you're going through it. So what brings the future? And the future is already now, because I have to advertise a little bit the new thoracoscopic instrument. There is better optics, high definition imaging, larger working channel, a more robust forceps, and a little bit more flexibility even that you can see the entry point. But also with the older instrument, it was already possible. So what this makes in the clinical practice, this is several years old thoracoscopy when we have chronic pleuritis, and we make biopsy, peeling biopsy with the old instrument. You see that the picture is a little blurred, that is not so resolute. But again, histology is important, we get a decent sample, but the visibility is not so good. So now with the new instrument, as you will see in a moment, so this is not the same patient. This is the recent procedure in a different patient, but with the same disease. So you can see a lot more details on the pleura, a lot more small vessels, early changes maybe in some different disease. Again, we see in very much details what is below the pleura, and we have a special modality when we can assess the bleeding much more accurately. We see bigger vessels, submucosal vessels, and we can change this imaging modality. It's called RDI modality. I'll show in the next slides what this means. So if we connect this new instrument with the new X1 processor, which is also available for a while around it. So this is the normal white image. Do you see something there? Okay, but now you see in the TXI image that there are small nodules. This is the beginning of the mesothelioma, the early mesothelioma. Maybe we could miss it with normal white light, but this is becoming a new standard, more resolute image, like texture and color enhancement. So all these modalities in the image, like texture, color, and brightness, are processed separately, and that's why we get more resolute and more contrast image. So I'll go once again to the same patients. Again, here are some small nodules, not so clearly visible, but when I change the image modality to EXI, you see that there are small nodules, which are basically the early mesothelioma, which was proven then with histology as well. So the next thing is a narrow band imaging. The narrow band imaging shows the superficial vessels in the chest cavity. What we are doing here is intercostal nerve block. We go with the needle in the vicinity of intercostal nerve. We inject a little bit of lidocaine and make an effective anesthesia for the whole half of the chest cavity. This is the patients where we will perform a pleurodesis. Pleurodesis is a very painful procedure, and we can do this intercostal nerve block for the whole half of the chest cavity in a matter of 1 minute. And the chest cavity is then anesthetized for almost 6 or 7 hours, the time when the pleurodesis is very painful. So you see, when we started with that, we saw, okay, narrow band imaging is showing us the vessels, and we can avoid the vessels, intercostal vessels, and that we are at no risk of bleeding. So I go to the next slide. This one slide is important. So here you see a lot of superficial structures, but you don't see in the depth. So this is one of complications. We have a bleeding because we hit a deeper vessel. This is actually a small self-limiting bleeding, but it's not nice. when we turn the image modality to the yellow one to RDI, red diachromatic image, it's just the opposite. We go deep through the pleura and we see even deeper vessels and we can avoid them. So it's another major improvement. So with narrowband, we don't see them. With that yellow, I go once again, we see them. It's the same patients. So you can see deeply through the pleura and avoid the bigger intercostal vessels and avoid the bleeding. So I will end now here. So pleuroscopy, what should every physician know? It's safe and effective. It spares you a lot of time. You get earlier diagnosis, more reliable diagnosis in the patients where you cannot establish diagnosis for just a pleural effusion. It's not so difficult to learn. From my experience, bronchoscopy is more difficult to learn than thoracoscopy. But it's a rarer procedure. You don't need so much skill. You learn your anatomy, you try several times in an expert center, you can do it. So Andrew can can testify that because he started to do thoracoscopies recently and he's doing a lot of them. And as we talked, you don't have complications because they are even rarer than in bronchoscopy. So the method is still underused in Europe, and it's really a shame because we have a nice equipment now, which most of interventional pulmonologists are familiar with it. It resembles a bronchoscope, and it's an effective, and it's not dangerous for the patient, and it doesn't need a general anesthesia and major surgery. So I would like to encourage you to use the method in order to benefit your patients. Thank you. If you have some comments or questions, I'm here available for you.
The insufflator, you mean?
Yeah, this.
You can just go back to.
Yeah, I'll try to. All right. So this device is commercially available. It's pre-packed sterile talc, graduated, and you already have now these catheters packed with it. But in the older thoracoscope, it was a little bit too thick. It didn't pass through the working channel.
In mild pleural effusion, sometimes. Mild pleural effusion. So I'm not comfortable to induce pneumothorax, honestly speaking. I don't know. Do you find it like really safe also to go just, you know?
Yeah.
And the fluoroscopy, I don't know how you...
So I'll show you. Use this atraumatic needle, which is meant, which has a blind tip.
Okay.
Blind tip, and is meant to evacuate pleural effusion. You just put it into the pleural effusion and open it, because negative pressure will suck the air inside, and the pneumothorax will be made passively.
Is this a specific needle comes to, or
Varus needle.
No, this is
It's called a Varus needle.
various needle?
Yeah.
VERRES.
blind tip needle.
Blind tip
Yeah,
needle.
it's available everywhere.
Is it the same that you use for pleural
Yeah,
pleural
the same
tap?
one.
I have
Yes,
a
that's
kit
it,
specific
that's
for
it.
pleural
Yeah.
tap.
Yes,
It's
that's
the
the
same
same
one,
Yeah.
green and red. Then you know where you are. It's the
Yeah.
same.
Yeah, that's
You
it.
just introduce the needle to the pleural effusion. You aspirate a little bit that you're sure that you are there,
Okay.
and then disconnect. The
All right.
pneumothorax
That's it.
will be made passively.
Okay. How do you make sure, other than the ultrasound? Can you see it in the fluoroscopy? Not really, right? In the
Can I see the
It's the pneumothorax is difficult to see in the fluoroscopy.
Right there.
yeah,
They are
here
all
it's
there.
seen on
It's
fluoroscopy,
in your-
but you can palpate it. You go with the needle as deep as pleural effusion and aspirate all the time.
Ah,
In one
okay.
moment, you will suck the water, and then you remove, and as far as you suck the air, such big is the pneumothorax.
And what's the worst that has ever happened to you? What is the worst complication
Bleeding.
that you have ever faced in real life?
The worst complication,
Yeah, in real life.
infection, empyema after thoracoscopy.
Oh no.
Yeah, empyema after thoracoscopy
Okay.
can be a severe complication, but nothing so dramatically as severe bleeding or whatever. But I think that empyema, if it happens after thoracoscopy, is a big complication. So we are very careful about preparing, cleaning, disinfection,
sterility, yeah.
Sterility, yeah. Sterility is the most important here.
Thank you.
Yes.
How much is better do the cold dredge during thoracoscopy or with the tube?
How better is
How
thoracoscopy?
better works?
Thoracoscopy than chest
Yeah.
tube.
Yeah,
Talc
talc and
slurry
slurry
versus talc could rush.
It's the same.
Yeah.
Maybe it's got different views.
Talc slurry versus that one. That's it.
The same.
Talc slurry,
Okay.
talc poudrage. It's
Almost
small
the same.
difference.
Oh,
It is
okay.
difference, but it's not a big one.
Okay.
Yeah.
Thank you.
I've got one more question. How do you go about patients when they come to you with already chest tube in and no
Yeah.
diagnosis? Do you go through the same port? Do you cut the
No.
tube and you go? So
No.
how you go separately from different side?
We disconnect the chest tube,
So
to
on the
introduce-
theater.
Yeah.
So now on the table. So you disconnect.
disconnect to introduce the pneumothorax. First, through the chest tube, we leave some air inside,
Okay.
taking up pneumothorax. Then disconnect the chest tube, and we enter different side because the first one is already contaminated.
Yeah. True.
So we have to go for the different clean side.
Okay. I'm sure.
And then when we insert another chest tube, another chest tube goes from clean side, not from.
Yeah,
Yeah.
definitely.
Yeah.
So you just keep it open to get air in, then take
Yeah,
it out,
then
then
take it
go
out
space
and-
above or anterior or posterior a
Yeah.
little bit,
And
right?
we close the first opening from the chest tube, but then we go to the second point,
Sure.
new side, and we leave the new chest tube in the new side.
Sure. Thank you very much. These are questions always running in our mind.